Hello, and welcome to this JAMA Clinical Reviews podcast. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. There were close to 40 clinical review podcasts in 2023, and the Clinical Reviews podcast channel is among our most popular with our listeners. I invited two JAMA editors, Dr. Greg Curfman and Dr. Linda Brubaker, to join me in choosing JAMA Clinical Review podcast conversations that were particularly noteworthy. First up is my pick. In May of 2023, JAMA senior editor Dr. Karen Lasser discussed the current evidence regarding diagnosis and management of cirrhosis and its complications with author Dr. Elliot Tapper from the University of Michigan. Cirrhosis affects approximately 2.2 million adults in the U.S., and the annual age-adjusted mortality of cirrhosis increased from 2010 to 2021. I wanted to highlight their conversation about the latest developments in the treatment of cirrhosis, including proven therapies that not only help our patients feel better, but live longer. Here's Dr. Tapper talking about common symptoms of cirrhosis and the evidence-based treatments for these symptoms.
So a lot of people are familiar with the canonical decompensations or symptoms of cirrhosis, like the ascites and abdominal bloating, the hepatic encephalopathy, the asterixis, the confusion, disorientation. But it turns out that if you ask patients with cirrhosis what's really bothering them, it's a set of symptoms that is both very common and independently associated with poor quality of life. And these include muscle cramps, which is directly related to the pathophysiology of cirrhosis. It happens predominantly in the lower body, but sometimes can be their hands or abdomen. Itching, because the liver is causing a backup of bile salts into the blood, which irritate the skin. And beyond that, these factors will also result in sleep dysfunction. And because cirrhosis disrupts many of the common endocrine systems, it will also cause sexual dysfunction for both men and for women. Now, the treatments for these are many, and we review them, but I'll highlight a couple. For muscle cramps, the things that are best tested are a sip of pickle juice, which, interestingly enough, triggers a nerve reflex that will abort the cramp, but it does not prevent the cramp. And so a studied drug is taurine, taken at about 1,000 milligrams twice per day. For itching, many of us will use bile acid binders because of the pathophysiology of the condition, like cholestyramine or cholestyramine. And sometimes we will go to second-line therapies like naltrexone, which mediate the sensation of itch. For sleep dysfunction, we really try to focus on sleep hygiene, but when we need to reach for another agent, things that have been trialed include hydroxyzine at night and sometimes melatonin. And when it comes to sexual dysfunction, the same things that would treat this condition in any other patient also apply, but it reminds us about two main things. One is that alcohol use disorder is associated with sexual dysfunction, and sexual function can return spontaneously with cessation of alcohol. And there are a variety of prescription therapies for erectile dysfunction that are safe and effective in cirrhosis.
And once patients develop complications of cirrhosis, are there other evidence-based treatments that they should receive?
Yes, each of these complications has a wealth of data behind it, and I will briefly summarize. For people with hepatic encephalopathy, this is a condition that is associated with frequent hospitalizations, falls, and trauma. And I think a lot of us know about lactulose, but what you may not know is that lactulose, when consistently applied in the randomized trial setting, is associated with improved survival. And when someone has breakthrough episodes on lactulose, rifaximin is approved by the FDA and is associated with improved freedom from repeated episodes of encephalopathy. When it comes to ascites, we have a variety of now older clinical trials which have established that the optimal therapy is a combination of aldosterone antagonists like spironolactone and loop diuretics, which largely function by protecting the patient from hyperkalemia. And these therapies will help resolve the ascites. But when they don't, there is paracentesis that's available in a pinch to help the patient with relief, but it will not solve the problem. And for people who are requiring multiple paracentesis, we will consider transjugular intrahepatic portosystemic shunts, or TIPS. And these procedures can be incredibly effective for patients with ascites refractory to diuretics. Now, for variceal bleeding, the best therapy is non-selective beta blockers to prevent them in the first place. And the most preferred one at this point is carvedilol, which is hepatically metabolized and therefore dosed once per day at a dose of around 12.5 milligrams ideally. But if someone has had a variceal bleed, that ought to be accompanied by serial endoscopies to place bands on any existing varices to make sure that they are completely obliterated.
So which agent should be used to prevent variceal bleeding?
Thank you for that clarifying question. Now, I did mention carvedilol, but the truth is that for people who respond to propranolol, either agent is preferred. So propranolol is typically a medication which is dosed twice daily, and we know that it is effective typically in people who achieve a heart rate on therapy of around 50 to 55 beats per minute.
Next, JAMA Executive Editor Dr. Greg Curfman will highlight an important JAMA Clinical Review podcast on heart failure with preserved ejection fraction. You'll hear the commonly used shorthand for heart failure with preserved ejection fraction, or HFpEF, and heart failure with reduced ejection fraction, or HFrEF, used in this podcast.
Thank you, Dr. Bibbins-Domingo. In March, I discussed the current evidence regarding the diagnosis and treatment of heart failure with preserved ejection fraction with Doctors Margaret Redfield and Barry Borlaug, both from Mayo Foundation for Medical Education and Research, Division of Cardiovascular Diseases in Minnesota. Approximately 3 million people in the U.S. have heart failure with preserved ejection fraction, and it is now the most common form of heart failure. Since our discussion in March, I've been thinking about the challenge to effective therapy for this common condition. Let's listen to part of the discussion that addresses therapy for heart failure with preserved ejection fraction, and specifically discusses the use of SGLT2 inhibitors. Now, Dr. Redfield, I'd like to turn to treatment of heart failure with reduced ejection fraction. And this has been a pretty tough history in that many therapies that may be effective for heart failure with reduced ejection fraction simply have not been effective in patients with heart failure and preserved ejection fraction. And I wonder if you could tell our listeners a bit about treatment, both pharmacological treatment and lifestyle interventions that may be effective in heart failure with preserved ejection fraction.
Sure. I think it's important to start with what does work. What do we know works? And finally, after, as you mentioned, years of negative or equivocal trials, we have a therapy that really has clearly been shown to be beneficial, and that's sodium glucose cotransporter type 2 inhibitors, or SGLT2s, such as dapagliflozin or empagliflozin. And 2 large trials, one with empagliflozin, one with dapagliflozin in patients with HFpEF, and a meta-analysis combining those 2 trials with trials of these agents in heart failure and reduced ejection fraction, show highly statistically significant benefit on the combined endpoint of heart failure hospitalizations or cardiovascular death. And that benefit was primarily driven by reduction in heart failure hospitalizations. However, pooled analysis suggests a benefit nearly statistically significant on cardiovascular death as well. And there's been some smaller studies with dapagliflozin that have shown clinically meaningful improvements in 6-minute walk distance and quality of life. So really, these two large trials, unequivocal benefit, suggest that we should use SGLT2 inhibitors in patients with HFpEF. Now, there are some important contraindications. You cannot use these in type 1 diabetes. You cannot use them in patients who have a history of ketoacidosis or who have severe impairment in renal function with a GFR less than 20 mils per minute per 1.73 meters squared. Relative contraindications, you want to think about it carefully and shared decision making with the patient if they have a history of frequent urinary tract infections or genital infections, because these agents make you lose sugar in your urine. They're diabetes drugs, actually, and so they can increase the chance of those infections. But actually, those were slightly more common in the trials in patients receiving these agents, but not dramatically. So that's the one drug therapy other than loop diuretics, if the patients have volume overload, that are of clear benefit in HFpEF. Now, there are some non-pharmacologic strategies that have been shown to be important, and that's educating the patient in heart failure self-care, make sure they understand the importance of adherence to their medicines and any dietary restrictions or fluid restrictions that might be needed. It's important that the patients learn how to monitor their disease, their weight, vital signs, and their symptoms, and that they know who to contact and how if their condition is worsening, and that can help avoid heart failure hospitalizations. Other non-pharmacologic effective strategies include aerobic exercise training, and in patients who have HFpEF and obesity, diet-induced weight loss and exercise training can improve exercise capacity and quality of life. So those are the things that are strongly recommended. There's a few therapies that can be considered, and this is mostly because of sort of equivocal benefit in trials. The first one, this used to be our only therapy for HFpEF, was spironolactone or eplerenone, a mineralocorticoid receptor antagonist. And there was with spironolactone the TopCat trial, which showed a trend towards benefit on heart failure hospitalizations and CV death, but not statistically significant. Another important drug to think about is sacubitril valsartan, the angiotensin receptor and neprilysin inhibitor drug, very effective in HFrEF. But the one big trial in HFpEF that looked at hard outcomes showed a trend, but again, not statistically significant benefit on heart failure hospitalizations or CV death. One other therapy that can be considered is implanting a sensor called a CardioMEMS device. It's a pulmonary artery pressure sensor that's actually implanted in the pulmonary artery and is interrogated by the patient daily with that information transmitted to a website. So it's a type of remote heart failure monitoring. And using that to guide therapy in 2 trials suggested a reduction in heart failure hospitalization that was particularly dramatic in patients with HFpEF. Some shortcomings with the trials that prevented it from getting a very strong recommendation, but definitely something to consider if you have the resources to do this type of remote monitoring and if the patient is really at high risk for heart failure hospitalizations. And then lastly, things that you shouldn't do. We talked about nitrate, sildenafil, and vericiguat not having any benefit in trials of patients with HFpEF. So that's really what we have for HFpEF right now. There are comorbidities that must be managed, but really these are the only HFpEF specific recommendations we can give at this time.
Let's turn to another key health priority, maternal mortality. JAMA Deputy Editor Dr. Linda Brubaker will highlight an important JAMA Clinical Reviews podcast that I hosted.
According to a March 2023 CDC report, the most recent U.S. maternal mortality rate is more than 10 times the rate of other high-income countries. In July of this year, JAMA Editor-in-Chief Dr. Kirsten Bibbins-Domingo hosted a unique conversation with Dr. Monica McLemore from the University of Washington, Dr. Audra Meadows from the University of California, San Diego, and Dr. Joya Creer-Perry, founder and president of the National Birth Equity Collaborative, to discuss these concerning maternal mortality numbers and explore why this situation is getting worse in the U.S. Here are key segments from the Maternal Mortality podcast.
There are three things that are striking in the numbers on maternal mortality in the U.S. The first is that they're high. The U.S. rate for 2021 was 32.9 maternal deaths per 100,000 live births. This is a number more than 10 times the estimated rates for other high-income countries. Countries like Australia, Austria, Israel, Japan, and Spain all hover between 2 to 3 deaths per 100,000 live births. The second important point is that the numbers are strikingly high in particular populations in the U.S., most notably Black women, whose mortality rates are more than 2.5 times that of white women. Hispanic women's mortality rates are at an all-time high and surpassing those of white women. For other populations, without appropriate data collection, we can't quantify the disparities accurately. And this is needed if we are to design interventions and allocate resources across all communities and populations. The third important point is that the trends are getting worse. More than 1,200 people died of maternal causes in the U.S. in 2021, a 40% increase from the previous year. And in every group examined in this new report, across all races and ethnicities, across all ages of pregnant people, the trends are getting worse over time. Dr. McLemore, what do you say when people ask you, how do we get here?
Well, I really appreciate the opportunity to clarify. I say there's three things. First of all, it has to be said that these deaths are preventable. Right? That's the one word I would add, that at a societal level, they are preventable. And we actually could prevent people from dying from pregnancy-related childbirth and complications. I would add, in addition to the clinical factors and the insurance factors, that there's a workforce factor that needs to be considered. And then we have to move away from the patient level factors. So we've blamed patients historically for their deaths, right? They come to pregnancy older and sicker and fatter, and they're not really in the best condition. That's actually not an individual problem. It's a societal and a structural problem. Whether or not people have access to green spaces or to healthy foods or to insurance or to clean water. These are policy and structural decisions. The most preventable deaths that we are aware of in terms of things that we could do right now happen in the postpartum period. It's estimated between 40 and 60% of maternal deaths happen in the postpartum period. It's the time when we at least have our eye on pregnant, capable people or postpartum folks. Right? Everybody wants to make sure lactation is good and we've got that family bonding and that the baby's doing okay. We take our eye right off postpartum person. And so we end up in a situation where if people are using different language or they're not being heard, they're not being believed, then you get multiple visits to healthcare providers and emergency departments and practitioners and office visits, but we're still missing it.
Dr. Meadows, I know you're a practicing obstetrician gynecologist, and I'm a general internist. And I think about one of those fragmentations that happen after somebody delivers is that you're taking care of them for a period of time. If they had hypertension, if they have something else, they might come to see me. And then there's that period after they deliver where, I don't know, are you seeing them or am I seeing them? Who's seeing them? How do you think about this system of care?
Yeah, the system of care is broken. I want to ensure that women can walk through any doors and have the same chance of receiving optimal care and optimal experiences as anyone else. And the systems of care have to be set up to be able to know that that is or is not happening in their systems. And currently, as it stands, many systems don't have that ability. Within OB departments, we don't even know exactly how many maternal deaths may be contributed to what's happening in our own facilities. We don't have data that's able to show us what's happening in a more upstream approach with severe maternal morbidity and some of those health conditions that we know are leading to maternal deaths. We haven't been able to look at our data. We have to be able to stratify that data by different demographics, by demographics that we know matter for the communities that we serve, because the communities that we serve look very different depending on the hospital system. You have to have systems and data systems set up so that you can understand that. But before you get to those systems and data centers that are set up to tell us the information we need to know so we can improve our processes, we have to have leadership to support having the resources to do that. And so that conversation has to be had from the top and work its way into the clinical systems of care that we're working within. There is a variation in care in the way that we hear issues and complaints from those who've just recently given birth. There are variations in care and when or where we see people who have recently given birth who are experiencing those warning signs, that many of the nursing groups are doing a great job of educating women on what those warning signs are. We need to be able to get them back into healthcare systems that can quickly and in a timely fashion identify what their needs are and then get them to the appropriate places and then administer that care. We know this to be true. I think many people have said it across the globe. Women are not dying from conditions we can't treat. They're dying from what we've already said are preventable causes.
We've talked about we have to reimagine and the transformation that's required to reverse these numbers that we're seeing. But what I've heard from Dr. McLemore and from Dr. Meadows is also just how important it is to also start and understand other aspects of health of populations that we're talking about, of Black people in the U.S., but also that as we're working towards the transformation, every single day we walk into our clinical settings, we teach the next generation. We have to be doing this work every single day. Any other points that you'd like to make that we haven't talked about today?
The point I would make is we would be remiss not to talk about Dr. Kimberly Gregory or Dr. Karen Scott, Black women OBGYNs who have developed patient-reported experience measures of obstetric racism, such that if you can actually measure obstetric racism, then you can consider it as an adverse event, independent of clinical events that occur during pregnancy and childbirth. Like, we have to tell people that pregnancy and childbirth prior to COVID-19 was the number one reason why people were admitted to hospitals and healthcare institutions, because we have like 4 million births a year. Most people will survive their birth. That said, it doesn't mean it wasn't traumatic and that an adverse event didn't happen just because you lived and you have your baby. So it's this whole other conversation of there are some really vanguard Black women OBGYNs who are pushing the boundaries of this notion that obstetric racism in and of itself is an adverse event and that it needs to be addressed as such. And I think that that is super important.
And CDC will let you list it as a risk factor for death now. So that's huge.
Is that right?
Yeah, well, we had to fight real hard for that. But yeah, so now when you do the MMRCs, when they review, you can list racism as one of the causes. And what it allows for you to do, what we find is in places like Mississippi, they never list it. In places like Massachusetts, with our colleagues, they list it on every case. But it allows at least for a conversation within the committee, right? So imagine that you're a bunch of physicians, it's usually a bunch of doctors. We know that. The MMRCs are highly overpopulated with doctors. And they have to at least, somebody in the room says, I think it was racism. That starts at least a conversation in Jackson, Mississippi. Right? That starts a conversation.
Well, I have to say, we are speaking about a topic that could leave one overwhelmed. After talking with the three of you, I have to say I'm feeling quite hopeful. If we can think about shining a light on this area, as each of you have said, these are preventable deaths. This is a pattern that can be different. And we need more people engaged in this conversation to understand where we are, but also to think about what the possibilities are for the future. Such concerning data. Thank you, Linda, for highlighting this conversation. Doctors Brubaker, Curfman, and I hope you have a chance to catch up on or revisit all the JAMA Clinical Reviews podcast episodes for this past year. There's a link to the full episodes that we've highlighted in this episode's show notes. There will be a steady stream of new JAMA Clinical Review podcast episodes coming your way in 2024. For more of our podcasts, please visit us online at jamanetworkaudio.com or listen and follow wherever you get your podcasts. This episode was produced by Shelley Steffens with help from Daniel Musisi at the JAMA Network. All best wishes for the new year, and thanks for listening.